IVM.
Welcome to All Things Policy, a daily podcast supported by Pragati, a flagship media initiative of the Takshashila Institution. We're a bunch of policy nerds based in Bengaluru, and we like to bring a fresh perspective to Indian affairs and an Indian perspective to global affairs. So grab a cup of coffee, sit back, and join us for today's chat.
Hello and welcome to another episode of All Things Policy. Today I have with me my colleague Priyal. So Priyal, how are you?
I'm doing good. How are you, Harshit? So happy to be here.
So the idea of this podcast came from a report we were reading, I think about 2 to 3 weeks ago. It was a Lancet Global Commission report on financing primary healthcare. So Priyal and we both have some interest in public health and we want betterment of healthcare for the people. So we do tend to pick up things like this and talk about this. So we thought our listeners might also enjoy this conversation. So Priyal, so this conversation basically started when Priyal started talking about a primary healthcare center near her home. So Priyal, can you tell more about that center?
Yeah, so I think what I had noticed was that basically my idea of primary healthcare center is that at least when you go there, you have the necessary facilities, right? You have the doctors, you have like the bare minimum necessities that you need. But I found that that was not the case, at least from what I understood of primary healthcare was, or my understanding of primary healthcare was that it is basic facility that gives you low cost or even free healthcare service that is provided by the government, and all the facilities in place are put in such a way that the people of, I think, the low income strata of the country can access these facilities, and people from that come from extremely difficult terrains and everything can also access. But my experience, or my from what I saw, I didn't think that that was the case in here. So that's the discussion that we were having, right?
Yeah. I think a lot of PHCs and sub centers, and even if you go up to district hospitals, the state of the affairs at these places is like quite bad. Yep.
Right.
There are a few exceptions, obviously. If you look at big cities, Delhi, Mumbai, then maybe at least the tertiary care hospitals are better. But
Yeah.
at least I think rural Bangalore or maybe rural Karnataka, even urban Bangalore, it's not quite good. It's like the building is quite old, the
Yeah.
healthcare personnel are not there.
Yeah. And I think also the thing is, a lot of people prefer private hospitals and everything. So not really too many people go to these public healthcare services, right? So at the end of the day, it's sort of like a cycle. Not too many people go there, so they don't get proper funding. And the reason they don't get too much funding is because not too many people go there. It's sort of like running around the bush. That's what I feel.
Yeah, that is a perfect explanation. So they don't get funding because people don't go there. So they don't have
Hmm.
the numbers. So they don't get funding. So they cannot improve and cannot
Yeah.
provide the minimum basic essential services. So people don't go there. And instead, that burden is shifted towards tertiary care hospitals, which it
Right.
shouldn't be.
Yeah.
Yeah. So that is the case, I think, for almost all the country. And it becomes quite difficult for the government and the patient, the person who is using the infrastructure to navigate through it. It is like we should be providing at least the basic essential services at a affordable cost, and while keeping out of
Definitely.
pocket expenses and while trying to like prevent further deterioration of the condition, and maybe looking at prevention and other public health, community health.
Definitely. And also, I think when we are talking about healthcare, it should include like maternal healthcare, newborn healthcare, child healthcare. It should also include like immunizations and, treatment of like common illness that you see in and around. And also, I think when we talk about, I mean, PHC, I think primarily the idea of it should be preventive healthcare, right? Because this is the first place you want people to go to with very basic ailments that they think of. That's where they should be directed. From here is where they should be directed to different like a tertiary healthcare facility or a specialized healthcare facility. Correct. And at the end of the day, because when you have people coming from to the primary healthcare, it sort of reduces the burden on tertiary healthcare in such a way that you are able to sort of space out the population very well. Otherwise, as everyone's running to tertiary healthcare for basic stuff, like even like basic fever or common cold or something, then you have a tertiary healthcare facility that's overburdened, and then you have a PHC that has no people coming in at all.
Yeah. And there's one more thing. So, for instance, you take TB. So,
Hmm.
TB, if you catch it earlier, there's a standard 6 months course which you can give, and there are like high chances then the person will be free of TB after that period. But
Yeah,
so you let it be, and if the disease like starts to deteriorate, so finally the person will go to the tertiary care hospital, the
yeah,
tertiary center, and the person will have to be treated at a higher cost
hmm.
to the person, the health cost, economic cost, social cost, and
Yeah,
higher cost to the government.
right,
Because instead of like giving him 10, 15 rupees per week or 20 rupees
yeah,
per week tablets, you now have to
yeah,
treat him thousands or maybe tens of
right,
thousands rupees of services and everything else. And
right.
you have to also take into consideration if you are sitting at the PHC, the cost of seeing one patient is like way less than when you're sitting at a tertiary care hospital. So
Definitely, yeah,
yeah, because we have a lot of infrastructure attached, the people there are specialists, the support staff is also specialist, and you're also eating into the time of a person who needs the tertiary care.
yeah.
Yes, sir. Obviously, if you want to reduce burden of the tertiary care hospital, we have to make our primary healthcare system stronger and more,
Yeah,
and
that
offload the care hospitals.
yeah, and also I think we are focused on India, right, at this point. But I think it's not just a problem with India. It's something that all the lower and middle income countries face this problem where so much of the healthcare is focused, or so much of the population moves towards the tertiary healthcare, that the primary healthcare centers don't really get any chance to intervene at the earlier stages, which then adds on to the burden of the for the country, right? You have too much expenditure from the country where you could cut down on expenses, like if primary healthcare resources are used or tapped in perfectly fine, you are, like you said, you will be able to sort of save up on a lot of resources and stuff.
Yeah. So the report is basically like they have like accumulated a lot of work and they have
Hmm.
some assumptions and came out with some models and they have laid the results basically in the report. So this was a paper cited in the report. It says that we are talking about only maternal and child health. So
Right,
for
yeah.
every like a rupee or dollar you spend in maternal child health, you get
Hmm.
around 7 to 7.5 rupees in benefits.
Oh,
So this is low income countries and 11.3 rupees in benefits. This is for every rupee. So
right.
even if you look at it from a perception of a pure economic cost thing, it's a no-brainer investing in
Yeah,
primary healthcare.
yeah, definitely.
Yeah, and the funny thing is, it's quite like an irony. So from the last 30, 40, 50 years, I
Huh.
think it was 1978. Yeah,
Yeah,
1978. The world has been pushing towards more primary healthcare and like intervene at the earliest, provide
right,
preventive community services. But
right.
instead, what we as a country are doing, we are providing more vertical health programs. For instance, we have a program for
Hmm.
TB. We also have a program for preventing blindness. We also
Huh.
have a program for dealing with non-communicable diseases. But this approach obviously it gets you results and it gets you results which you can show on a graph. For instance, you
Right.
can the incidence of TB has fallen, the incidence of polio has fallen. But
Hmm.
it is important. It is more important that we strengthen our primary healthcare infrastructure. It is more
Right.
important that we shift our focus from these disease specific vertical health programs to sort of all rounder primary healthcare.
Yeah, and I think, like, based on what you said, right, especially, I think the pandemic has sort of like highlighted the need to focus on primary healthcare centers, right? Because especially in countries like Japan, Vietnam, and South Korea, where they have very strong primary healthcare centers, they were able to respond faster in the during the pandemic, and also more effectively. They had all the sort of like to carry out surveillance or to monitor the people and all of it. They had better systems in place because they had a very strong primary healthcare structure. And sort of also like it sort of becomes a very good platform for controlling the infectious diseases. And I think pandemic in general has brought back that focus, and it's good to see that people are talking about it and people are understanding the importance of this rather than just focusing on, because I think at a point India kind of like got so wrapped up around the whole specialized hospital specialization based care models, and sort of like like you said, light vertical models. But going, I think, at a broader base, sort of like going from broader base to a pointier apex is like an approach that we should talk about.
Yeah, yeah. Even if, for instance, there is a Indian public health standards which were last updated this year, sometime early this year, after a long time. So they say that,
Hmm.
for instance, for one PHC, that is the primary healthcare sector, we are talking about rural areas, should be for one PHC for every 30,000 population. And if we
Right,
talk about helium areas, that it should be for 20,000 population,
right,
and
right.
so on, and more than one polyclinic for 2.5 to 3 lakh population, one PHC in urban area for 50,000 population.
Hmm, hmm.
So I think we can improve these standards, but first we'll have to reach them. We have not even reached these standards, because if we want to
Right.
provide good preventive and primary care to the person at a low cost, at a cost that the person can bear,
Yeah, yeah.
these we have to then these numbers. A lot of states in the country are even lagging to like get to these numbers. And even if there
Right.
is a PHC for as per the population norms, it does not function properly.
Hmm,
Health
hmm.
personnel or
Right.
they don't for an hour or so. Or there are a lot of
Yeah.
like a
And also, I think
lot.
if there are no necessary facilities, then those people have, I mean, it's sort of like, see, if you actually go to a PHC, right? And they have no necessary, like a lab to see do the testing, or the necessary contacts with the lab to do the testing and get the reports and everything. And if the PHC is going to be like, oh, you have to go there and do the testing, you have to go to that doctor at this particular clinic and get the report, blah, blah, blah. Then obviously the people are like, why should I go to PHC only to be redirected to other places? Might as well go directly to a tertiary healthcare center where everything is in place. So I just have to walk around the hospital rather than, jump from one place to the other. It's sort of that logic also applies, right? In a few places. So, like, proper, I think getting a proper PHC infrastructure in place would sort of be the beginning to where we want how we want to better the PHC organ.
Yeah, so that is that is quite a good point. And for instance, I am a person who gets his daily
Right,
wages. I don't want to spend one day at the PHC, wait in line, wait for the
right,
doctor, then wait for the medicine, and be told that, oh, so these medicines are not
right, right.
available, get them from outside, or be referred to a tertiary care center and then spend my whole day there. So it
Yeah,
doesn't make sense, obviously. So I've worked for some time in sort of a UHC and a CHC in rural Maharashtra,
right.
and for some time in Delhi. So this is definitely the case. But yeah, so in Delhi, there's an interesting thing. There are sort of like, you can call them urban PHCs, yeah,
Okay.
the UHCs, the mohalla clinics that
Right,
the
right.
government is. So at least what they appear to be, and what anecdotal
Huh.
evidence I have, is that they're working quite well. And what people have seen, I don't have any hard data right now, which I
Yeah.
can refer to, but what
Right.
I had seen and what my friends and colleagues have seen is that, because in a place in which there are like 4 or 5 functioning mohalla clinics, the type of cases which used to come in the hospital's OPD have changed. So
Right.
previously, simple cases used to walk in, but now there is ease of access. A lot of tests and a lot of medicines are available at mohalla clinic. So the
Right.
people who come, who are referred to the hospital, first of all, they are referred for specialized care. So
Right.
that is better utilization of the services available at the hospital. And the simpler cases are not simply not referred. So people don't
Right.
want to go to a hospital, waste their day. It's better they spend an hour or two in the mohalla clinic, see a doctor, get their medicine, get their test done, and then they
Right.
can go home. Obviously, there have been some changes, and this appears to be a good model.
Right.
Yeah, so there's an interesting thing. Do you know, Priyal, how ASHA workers are paid in Karnataka?
I don't know how much they are paid and stuff, but do you have any idea?
Yeah, so ASHA workers basically all over the country are paid a fixed amount and plus some
Okay.
incentives. In
Right.
Karnataka, it is rupees 4,000 a month plus
Oh,
incentives which can reach from, I think, 4,000 to 12,
right,
16,000
right.
something. There are a lot of different ways in which the commission, at the Lancet Commission,
Mhm.
advocates paying the providers. So
Right.
this is sort of a pay for performance review system.
Right,
And
right.
this is how the Delhi government pays the people at basically the doctors in the mohalla clinics. The last payment I know is it was somewhere near rupees 40 per patient,
Hmm. Hmm.
and the minimum number is 75. So you are paid for at least 75 patients,
Right.
and more patients you see, the more you are paid. So it's a good system. Obviously, there are leakages. Obviously, some people
Yeah.
try to take advantage and everything like that. But it is a good system which pays the person as per the requirement of the area,
Right.
for as many people they are saying.
Right.
And the commission also advocates sort of a fee for service. For
Mhm.
instance, if the doctor does an operation or does a delivery, he's paid a fixed fee for that. And
Huh.
they also advocate a capitation payment. For instance, this is what is done in the National Health Service system in the United Kingdom. They are paid the GP, general practitioners, that are the first contact
Right.
for a person in the system. They're paid a fixed sort of like fee per person. Each and every one, each and every part of like every way of paying has an advantage. But
Right.
we'll discuss it later. We'll discuss it sometime later.
Yeah. Actually, Harshit, before we move on, given that we are now moving towards the financing aspect of primary healthcare center, let's take a short break and we will resume right back where we stopped our conversation.
Hello, it's been another great week on the IVM Podcasts Network. On Cyrus Says Cock and Bull, Cyrus, Naveen, Priyanka, and Abbas discuss rapper Sidhu Moosewala being shot dead in Punjab. On Edges and Sledges, Ashwin, DJ, and Varun review IPL 2022 and discuss how the Gujarat Titans lifted their title in the first year. On Simplified, Tony talks to Nivedita Prakasam on how to make it in stand-up comedy. On All Things Policy, the Takshashila folk discuss how trade policies can be harnessed by India to improve its existing ecosystem. And on the Life Manifesto, Zarina shares the benefits of being spontaneous. We've got some exciting news for you. IVM Podcasts has just launched its merch, and our first line is out now. Head to the IVM Podcasts website and click on the Shop tab to check out our first collection of t-shirts. Do follow us on social media. We are IVM Podcasts on Twitter, Facebook, Instagram, and LinkedIn. And remember, if you're enjoying this show or any of our other shows for that matter, please do tell a friend. Also, don't forget to rate us on any platform you're listening on. And you can also check us out on YouTube. We're also doing a small listener survey to better understand how you respond to our shows and advertising on the network. We would really appreciate it if you could spare a few minutes to fill it out. It helps us build better shows for you. And finally, we would like to thank our sponsors this week: SBI Life Insurance, Jupiter, a digital banking app, Cap Gemini, get the future you want, Intel V Pro, built for business, and Intel, future banao wonderful with Intel powered laptops.
Hello and welcome back to this episode of ATP where we are discussing about the primary healthcare and the financing aspect of it. And before the break, we were talking about the problems associated with PHC and in a broad sense, what is currently in place and how we can sort of like very vaguely touched upon what can be done better. Now, we are getting into the financing aspect of it, right? We understand that one of the ways to sort of better the structure is to fund it adequately so that they have the necessary facilities, they have all the things that is required for the people to go and seek these services. It's important that people start taking help to going to the PHC centers because we understand that the tertiary healthcare centers are getting overburdened. when PHCs are ignored. So when we are talking about like primary healthcare centers financing, Harshit, considering that you also have an experience working in, urban healthcare centers and everything, and also in this paper that we were talking about in the Lancet, so how can we sort of go about the public healthcare center financing?
So the paper, basically the report, it talks about that you have to first think of financing in three levels. So
Right.
the highest level is in which this is the macro viewpoint in which the government and the healthcare system, they bring their think about their vision, and they see how a comprehensive primary healthcare infrastructure will address the population's health needs. At the second level is the benefits package level, in which
Right.
the government and the health system must identify which services it can afford to provide. So it's either for free or with partial coverage. The third level is the provider payment level, in which the health system must determine how will it pay the providers, at what level will the payment be made, what is the mechanism. So the commission basically advocates that if you want to think about primary healthcare financing, you should think of it in three levels. First is macro level. Second is the government thinks what it can provide and what it cannot. And the third level is the provider payment level.
Right.
So
So,
this
one question before you move on is that this is all based on the assumption that the healthcare is free, right?
no, so healthcare is affordable. We want to make healthcare affordable, not free.
Right,
And
right.
this is primary. We are talking about only essential services as such. And you have to take into account the country's fiscal capacity, population health need. And one important thing is the political will and the political discussions about health. Yeah, and I don't think India at this stage can even think about providing universal health care free for all. You could provide emergency and essential services free, but I would advocate for a progressive pricing in which the person who cannot pay does not pay and the person who can pays as much as he can. So one comparison I would like to use, I tend to use this. So you have to compare TB with terrorism. It's a very toned down, simplistic comparison. But TB killed around, this is pre-COVID numbers, TB killed around 14, 15 lakh people in India in 2019. And terrorism killed less than 500 people. These include the terrorists. So if you look at the budget we allot and the focus which is given to terrorism as compared to TB, you'll see the difference. And it all boils down to sort of like public perception and political will. So public, for instance, even if there is a plane crash, one plane crash, it's all over the news and lakhs of people die in car accidents. So it's all about perception and political will. So if we want primary healthcare to succeed, we'll have to like shift our resources away from other sectors and shift them to health. And it will take a lot of persuasion. It will take a lot of
Definitely.
uh,
Yeah. And I think from what you said, right, when you compare TB versus terrorism, I think people refuse to understand is that the scale of the public health burden, disease burden that TB is, whereas people just sort of like, it's sort of, feeling that because the terrorism deaths get televised so much that automatically people sort of empathize with whatever happened. And when the TB deaths happen, no one really knows, right? It's just a stat in a book, that kind of a thing.
yeah, TB that is just a number
Right.
in
Yeah.
a government ledger which calculates how many
Exactly.
people
But
died.
like TB is one of the biggest health burdens of the country. And that is something I think the majority of cases in the world for TB is in India. India is one of the hotspots for TB. If you go through like the official websites of it and everything, you will see that.
Yeah, a lot of TB burden is in India.
Yeah.
And so even within healthcare, you look at what the government or the political class or the people want to see is they want see a new shiny hospital wing or a new MRI machine in a district hospital, and that will win the government accolades, and that will win the person who did that promotions and the politician votes. But getting a new PHC or improving a new PHC will not be so
not
impressive and
Garland worthy, right? Because like, for
yeah,
example,
yeah,
you get an you get a new MRI machine, all the newspapers will cover it, you get all the accolades. But 3 months later, if it gets spoiled and does not get repaired for the next 10 years, nobody even bothers about it. It's not a national news. Correct. So like getting an instrument is easier. Maintaining that instrument and making sure that people get the benefits of the instrument, that is difficult in our country.
yeah. So political will is difficult at so at three levels. For instance, health versus everything else. It's not versus, but health and everything else. Within health and within even within, for instance, the primary healthcare system or within even the tertiary healthcare system. So you have to spend money, you have to spend more money, but you have to also spend the money more wisely. So the commission report also has a lot of data which and it reiterates this line. So spend money but spend it wisely, because even if you look at companies in the similar income group spending similar amounts, they have a lot of variation in public health outcomes. And one of the main reasons of that is because they're not spending money smartly, or they're not putting money where they should be putting.
Right, right. Priorities matter, right? Where you're prioritizing your spending. So, are you spending on the things that could give you like good outcomes, or are you just spending simply because you have the money to spend? That's, I think, the logic behind it.
Yeah, and so one more thing that if you look at funding primary healthcare is you cannot compare the funding across countries or maybe across regions, because there is no definition, concrete definition which says that this
Mm,
is primary healthcare. For instance, the report says that primary healthcare financing, if you look at primary healthcare financing, you should also include things like sanitation, pollution,
right.
road safety, because they are sort of like preventive in nature, they affect your
Mhm.
health and things like that. But and unless you can look at two regions and compare them,
Yeah,
you cannot get bit, because you do not know the best practices. You don't know if state B or country B is doing better than country A, so you cannot
right.
adopt their practices. You do not know where to put your money. And data in India is
Yeah,
obviously the problem all across the world. But in
yeah.
India, data is
It's,
very horrible. You
yeah,
cannot get.
whatever is a understatement, maybe.
So even if some government agency did some survey,
Right.
if you want to access the data, it's like super difficult. Maybe you will
There's
get a
no
report.
transparency, right? So even if the data is there, how was the data obtained? What was the process of it? And how ethical was it? All of it. There's so much of layers for obtaining data and showing it also. So as there needs to be transparency also. You can just randomly put some numbers and say that, oh, this is data. But how did you obtain that data is also very important. And I think that's exactly what's missing in our country.
So there are a lot of nuances to these numbers.
Right.
And obviously data is politicized, has a political sort of like, numbers always have a political motive. So you have to look at nuances here. Even so, the government is not ready to release that kind of data, and you cannot. It's not very easy to see that data. But
Right.
so it's very strange. So if you want to like apply for a paper in a good journal, a lot of
Oh.
times the journal will ask you for your master sheet, or
Hmm.
does ask you for it's, even if the paper is not that significant, does not have a
Right.
large number, the journal is not that prestigious, but the government expects you to like accept whatever they tell you.
Right.
This also has a numbers, and they have made X more PHCs, even though those PHC don't open, so nobody stays at them. So, and we will not tell you how we collected it, and we'll not
Right.
tell you the nuances, but this is what we have, take it or leave it. So it's a
Yeah.
very strict thing with data, and obviously the definitions and data obviously matters a
Right.
lot.
But like now, if you're thinking, we know that funding PHCs is very important. And if we have to consider funding the PHCs, like if you were to think off top of your head and even like from the Lancet report, what are the few points that, speak to you very much? In the sense, one of the things that spoke to me very much was, the part where it says paying for medicines for the PHC, because a lot of the medicines that people pay for even after getting treated on PHC is their out of pocket expenditure. So having the medicines paid for, or having like structure where the medicines, etc., comes from the PHC is one of the ways to go about it. So funding there is very important. What are the other things that you can think of when it comes to, the funding side of it?
So I think giving some degree of autonomy to the
Right.
public and the primary healthcare infrastructure would do, and some control over their budget, some control over
Mhm.
their salaries. And medicines do make a lot of the budget, and there are provisions which says that medicines should be freely available. The
Uh-huh.
medicines should be available, they should be free for patients. But a lot of times, maybe the majority of times, even basic medicines are not available. So
Right, right,
unless we like fix these things up and we sort of like push, like nudge people towards PHCs, towards primary
right,
healthcare, we won't be able to get good outcomes and good outcomes at an affordable price.
right.
Yes, and I remember what you said in the starting, the vicious circle. PHCs, people
Yeah,
don't come to PHCs, so PHCs don't get funding, PHCs don't get better, so people don't come
yeah.
to PHCs.
It's
It's a cycle,
running
and
around the bush, right? You just keep running around the bush for the same exact problem. That's it. There's no end to it. There's no beginning to it. And it's just unless you put a break at one point and nudge the people to go to PHCs and show the data that there is enough number of people so that PHCs get funding. That is one way to go about it. Second is to first invest in making the PHCs better so that people are motivated to seek out these services, because I think one of the incident that happened was one of my acquaintance wanted to go to a government hospital, maternity hospital, and that was a newly constructed hospital at that time. So all the facilities were there, all the instruments, doctors, specialists, everyone was there, and it was a community center. And she had most of her delivery and everything was free. But 2-3 years later, when another of my acquaintance out, because this person had recommended this hospital to her, went to the same hospital, 3 years down the line, half of the machines were broken. Half of the people had left that place. The services were not as good as when they were first opened. So you see what had happened, right? Within a span of 2 years, so many things had changed that the number of people who were seeking these, facilities had gone down to like quarter or less than that. So not just like funding PHCs to give better facilities is yes, but maintaining those primary healthcare centers is also very important. You can't just like throw in money and say like, oh, we've built a new thing and then forget about it. Constant monitoring and maintaining them is also one of the things that we should think of.
yeah, so instead of just cutting the ribbon and
Yeah.
getting the
Accolades
newspaper.
for it.
So
Yeah.
yeah, new MRI machine, new hospital wing, and then there is no funding for its maintenance. It's better if you try to maintain and upgrade existing infrastructure. It's also super important. And one more interesting thing that I read and I've seen is, so the paper also pushes for digitization. It says that using digital infrastructure and using artificial intelligence, primary healthcare can be made better. It also point out towards ashas. Ashas are now required to fill a digital, so they have an app to fill out how many deliveries they did, how many houses they visited, etc. And this is how they get paid. But obviously, there are a lot of problems with this digital push. But
Digitization.
at least
Yeah, yeah.
it makes it better to get a little bit
Yeah, it's a
better
nudge,
data.
right? It's sort of like, yeah, it's sort of like a start for something better, maybe. And we'll have to know how if the implementation goes well, maybe it's a good thing.
Yeah, only if the government releases the data in a timely
Yeah,
and a
right, right.
good
Definitely.
format. Fashion, yeah.
Yeah.
So, Priyal, I think we'll just stop here. And yeah, so to listeners, we'll also have a part two along the same topic because we had a lot
Yeah.
of
There's a
good
lot
stuff
of
to.
points. Yeah, yeah. There's a lot of points that definitely need going deeper into. And we've only, I think, discussed one half of the paper. And we'll definitely come up with a part two where we continue discussing this paper and basically about mobilizing the resources and political economy, and as well as how to make primary healthcare centers more people centric, because up until now we've discussed about financing, right? So now I think we will move a little further deeper down.
Yeah. So thank you, Priyal, for being
Thank you,
here.
Harsh. Yeah.
For such a wonderful discussion. Thank you, listeners, for listening to us, and stay tuned for our part two sometime in a week.
Soon. Yeah.
If you liked our show, don't forget to check out other interesting podcasts on the IVM network. You can tune into them on the IVM Podcast app, ivmpodcast.com, or wherever you listen to your podcasts. You can also follow IVM on social media. The handle is @IVM Podcasts on Twitter, Facebook, and Instagram. And hey, if you'd like to dive into Takshashila's research on technology, strategy, and economic affairs, check us out at our Twitter handle @TakshashilaINST or our website takshashila.org.in.
There's a quick survey to fill out on ivmpodcast.com/survey. It lets us know a little bit more about who's listening to us. And you know what? We're going to do a few prizes. So, we'll do a random drawing of maybe 10 people and we'll send you all some swag. Remember, that's ivmpodcast.com/survey where you can fill out the survey.
Remember the days when our granny used to narrate once upon a time stories? Let's bring back the good old days of moral stories with Storytime Tamil. Hi, I am Ravishankar Balachandran, host of Storytime Tamil podcast. I would like you to entertain and educate your children with stories from Storytime Tamil. Tune in to the new episode sharp at 7 p.m. every day on IVM website, IVM podcast app, YouTube channel, or wherever you get your podcast from.